Hello and welcome. I'm Dr. Rachel Bond. On behalf of CME Outfitters, I'd like to welcome you today and thank you for joining us on an educational activity entitled Health Equity in Cardiology Care, Bridging in the Front Office. Today's program is supported by an educational grant from Johnson & Johnson. My name is Dr. Rachel Bond. As I made mention of, I am the System Director of the Women's Heart Health Program at Dignity Health in Arizona. I'm also an Assistant Professor of Internal Medicine at Creighton University School of Medicine, and I also co-chair the Women and Children's Committee for the Association of Black Cardiologists, where I sit on the board of directors. I'm delighted to be joined today by a distinguished group of exceptional women, and I actually want to give them the opportunity to introduce themselves. So let's begin with Dr. Calhoun.
Hi, I'm Linda Calhoun. I'm a practicing general cardiologist in the Wilmington area for the past 31 years. Although I spend every 6 weeks in the hospital rounding, I also do the majority of my practice seeing patients in the office. I'm also a clinical instructor for internal medicine for medical students and residents as part of the UNC Chapel Hill and CHEC education system.
Thank you. And Miss Yvonne Dixon.
Good afternoon, everyone. I am Yvonne Dixon, and I am thrilled to be here with you this evening. When we talk about nursing, that is my chosen career, and I chose that almost 40 years ago. So just in thinking about how long I have been with the field of healthcare has truly been a wonderful experience. I am currently the Director of Health Equity in the Office of Health Equity here at Novant System. And knowing that health equity is such a wonderful topic to talk about, it's very deep discussion as well. That deep discussion also falls over into the area of UNC, Chapel Hill, the Novant Health Campus. This is located in Charlotte, and I am on faculty with this campus, charged to be able to share with students about health equity as we know it within Novant Health and also our communities that we serve. Again, I am very thrilled to be here to share as well as to listen and learn.
Thank you so much for that introduction. And last, but certainly not least, Mrs. Chanel Newton.
Thank you, Dr. Bond. And I'll say the same thing. I always say I'm just so excited, for the opportunity to, bridge the gap of my passion for diversity and inclusion and for community engagement. And I think, having that opportunity to lead in different areas. Right now, I am a clerical supervisor with Novant Health Heart and Vascular. And I do have, that experience of knowing the importance of the front office staff. And I'm just excited that we get the opportunity to share what we love to do with great leaders who happen just to be great, powerful, but humble women. So thank you.
Thank you all. And honestly, thank you for all that you do. I think we are in for a delight with this programming. And before we get into the programming, I do want to review a few of the learning objectives. Our singular learning objective is to recognize the positive impact that the front office staff can impart on health disparities in patients coming into the cardiology office for care. Oftentimes, the front office is really the first set of eyes and ears that our patients have exposure to. So we hope by the end of this actual wonderful discussion, we have a better understanding of the impact that the front office can make. And I think for us to begin this dialect, I would like to start by setting the stage with some key terms and very important concepts that impact how our society functions and how we actually got here. These are concepts that we should be very familiar with, but more importantly, very mindful of, because they do help to allow our patients to feel more comfortable as they're seeing us. And I would like to give this first slide and question to Ms. Dixon. Could you perhaps introduce some of these concepts for us so we have a better understanding of each and every one of them?
Yes, Dr. Bond, thank you so very much for sharing about these defining terms, because when we're looking at how to be able to bring all of this education into focus, we must be able to start with defining terms. And again, as you stated, we must already know these, but again, I'm a preacher's kid, and my dad often told me that even though folk may think they know it, it's always great to bring it to their attention. And I used to listen to those sermons, and those sermons, it would be repeated at least 7 times during the course of one sermon. So when we're thinking about these defining terms, let's start out talking about equity versus equality. Now, we recognize that we hear about equal rights, everything's equal, but we also recognize that everything's not equal. And when we think about equality, it is when everyone receives the same thing. Now, the other aspect or the other side of that coin is equity. And when we're thinking about equity, that is when everyone gets what they need. Now, I have an experience where I was at the doctor's office and I speak English fluently. The person that stood behind me, I heard that person talking on the phone, and I know that their English was their second language. So I wanted to make sure that I saw what was happening here as this person behind me was being registered in. And the person spoke to me, and I say the front office staff person spoke to me in English, very clear, understood it all. When I went to be seated, I listened to the conversation that was happening with the person that was behind me, and I was delighted. The front office staff person spoke Spanish. That was very delightful because I knew that what was happening here, even though it was equal delivery of information, but there was also equity delivery of information because of this person there being at the front office. So again, those are differences that we see, equity versus equality. We often know that implicit bias plays a great deal in terms of who gets what and how much, right? So when we're thinking about that implicit bias, some folks call it unconscious bias, also known as implicit bias, but it is unconscious attitudes and beliefs that we have about persons, places, and things. And so when we're thinking about that implicit bias, we often know that we are overwhelmed with a lot of information during the course of an interaction or an experience with a patient. But because we are overwhelmed with all of this information that we're taking in, what happens is that our thought processes just really go on what I consider a pause, because we take in all the information, but then we realize that I will divert to what I know. And because what I know may not even be what is the case for this particular patient, but we divert to that because it's a comfortable way of being able to interact with another person. That implicit bias, everybody has it. Everybody has it. Mm-hmm. And the best part about implicit bias is knowing that you have it, being aware that we have it, because when we operate outside of our consciousness, then we'll get it wrong every time. So implicit bias, again, is something that everybody has. And I often say, if you're breathing, you have bias. And so these biases can be most uncomfortable, especially when we don't talk about them. And so when we're talking about the other term, having to do with pronouns, usually beside my name is pronouns. I have pronouns, her and hers, okay? Those are the pronouns that I use. However, at the front office, usually individuals are not so much using pronouns as they are just basically introducing the patient to the surroundings. So the first interaction that a patient may have in coming to the front office, that patient service coordinator may say, "Hi, I'm Yvonne Dixon, and I'm here to serve you today. And how would you like for me to refer to you?" I think asking these questions is truly very important, rather than just assuming that that person may be a female in front of you, or just assuming that person may be a male in front of you. You know, it used to be we would say Mr., Mrs., and Miss, but now we don't say that anymore. More or less is after you have gotten to know this person and they have shared with you how they would like to be referred to, that is when you utilize those gender affirming pronouns, and also just basically addressing that person by their identity that they have shared with you. And then finally, cultural humility plays a great portion in all of our interactions. We say that we want to be culturally competent, yes, but cultural humility is the first step. Because when we are able to self-reflect, when we are aware not only of what we are saying, but our interaction with the person, then it opens up for greater understanding of all cultures. Again, cultural humility, that is basically about being introspective, being aware. And then when you close the loop on that, you certainly will have a greater understanding of what equity and equity and equality is. You will have a greater understanding of what implicit bias is, and you have a greater awareness. And then also you may start utilizing those pronouns for gender affirming care, because after all, individuals want to feel as though that they belong. And there's nothing worse than coming to a practice and made to feel as though that you don't belong here. But it does happen. So thank you, Dr. Bond, for allowing me the opportunity to define some terms that are truly very important to our discussion today.
Yeah, no, thank you, Ms. Dixon, for that very, very powerful kind of walking us through what these terms mean, but more importantly, the examples you provided. I think it left me with a lot more insight, and you brought up a very key word, awareness. I would say largely from an awareness perspective, we know, and I'm going to move on to sort of the next segment, because I know from an awareness perspective, for us to be aware, we really do have to understand the causal chain of why health disparities exist. And I'd like to throw this question to Dr. Calhoun, if you can perhaps delve a little deeper into what these health disparities are, but what the causal chains are that led to them, just to help us framework the conversation a little bit better.
Well, thank you. When we talk about the causal chain of health disparities, we're actually looking at multiple factors: social and cultural norms, racism, sexism, classism, homophobia, transphobia, ableism, institutional powers, governance, practices, policies, regulations, and laws, social determinants of health, physical environment, social environment, economic environment, service environment, individual actions, smoking, nutrition, physical activity, alcohol use, drug use, and health disparities, wellness, disease, injury, and death.
Absolutely. And, Ms. Newton, out of all those that Dr. Calhoun listed, do any of them stand out to you? And what particularly are your perspectives on maybe one or two of them?
I would say, thank you, Dr. Bond. I would say, Dr. Calhoun, what I'm grateful for in Novant Health is that we do get the opportunity to really be intentional about the social determinants of health. And I feel like that's something we get the opportunity to when we're welcoming our patients into the clinic, because we don't know. You can't look at somebody, and judge them from the way most of us were taught is the golden rule. Treat everybody the same, but we don't treat everybody the same. We ask you how you want to be treated. In different community engagements events, we don't just say, Mrs. or Mr. and or Mrs. And, having the fortunate opportunity to go through diversity facilitator training through Yvonne, I learned so much. And it stood out to me when she was saying like implicit bias, that we all have it. But one of the things that I learned a lot is how to tie in the social health of determinant with different biases that we've had for years, but we didn't even know about it. it gives you a lot of accountability, because I want every patient, whether it's my parent, they're walking in a clinic, to really feel like that I care about it. So I also take personal and professional, responsibility to make sure that that I'm delivering that. And so many people in my circle of influence, they depend on me. So what I do, it comes out, and they not mimic it in a way that it's a joke, but they really are able to live out that experience, because we're welcoming people into the clinic. And so I think the social determinants of health, they're very important, and it ties into a campaign that we had some years ago. We put stickers, in our in all of our windows, the doors, and it says all are welcome. So even people who didn't know what we were talking about, it was a statement that people would ask, what does that mean, all are welcome? Then it gives us the opportunity to discuss it. And then it lets people know at Novant how we really do mean what we say. It's a part of our promise, but we're committed to it. And we want to make sure that people are aware, whether it's a team member, a patient, a provider, we believe in it. And we want to use that opportunity now that we get to teach people that maybe they didn't learn 30 years ago in college, but now they get to learn it. And so I feel like at our organization, you're able to learn something that maybe you didn't have an opportunity to learn, and how to tie that in.
Oh, thank you so much for sharing such a forward-thinking mentality. And, you bring up a very valid point that to date, it's easy enough for us to say all are welcome, but there was a point in history where all were not welcome.
Right.
And I think understanding the historical context of where we were, even where we still are, is what helps to pinpoint a little bit better these healthcare disparities.
Mm-hmm.
One aspect of what Dr. Calhoun brought up was systemic racism. And I wanted to delve deeper, a little bit deeper into that, because it's important that we truly understand what structural racism is,
Mm-hmm.
how it permeates into our healthcare system, and how even now in the year 2023, almost 2024, it's impacting us and our patients. And I would like you, Miss Newton, if you could expand a little bit on what your thoughts are with systemic racism and how you think it affects your patients.
I will say, I definitely know it affects, our patients. I've been one of those patients that went into a clinic and the doctor would not touch me. So sometimes you think people look at you from the outside. Sometimes they judge you. Oh, well, she looks nice. She looks professional. She may come from, a good background. So I want to treat her well. No, I've experienced of not being treated well. I lived in that same, suburb as the doctor. I work for Novant Health. I'm behind the wall, like that person who's operating to carry out our brand promise. So to me, to be treated that way, you're like, oh my gosh, imagine how other patients are feeling. Systemic racism, excuse me. I've seen the effects of it, with our patients, where I've seen sometimes, like Yvonne and I both talked about it with our diversity and inclusion training, that we teach that, and we want to hold people accountable, because you don't know what you don't know. And sometimes we don't all take the responsibility. We may feel it's a certain race, or that's not my responsibility because I didn't do anything. It's going to take all of us to be a part of changing that systemic issues that still happen. And healthcare is so bad because we have the opportunity to change somebody's life in healthcare. So when they walk in the clinic, they're coming into heart and vascular. It ties into their heart because, number one, they've gone to the ED most times. It may not be a really serious heart issue, but when they come in, they're already scared. So what I have talked to our patients about is that they like come in and they see somebody like me. They see, team members. They see whether it's a CMA or a clinic administrator or a provider. They'll ask, well, am I going to be treated a certain way because of the way I look? Am I safe here? I'm able to say, yes, you will be safe here. We will take good care of you. And we have, providers who look like most people everywhere you walk around Novant. And so I'm proud to and it's a humble proud when we have team members come in and patients come in, and they are so grateful for the diversity that we have. And it helps them break down what they've been taught, what they believe, maybe from their parents, and it gives them an opportunity for us to take care of them, and then they feel safe.
Those examples were great. I was going to ask Miss Dixon, if you want to expand.
Sure. I'll give you a personal example.
Yeah.
When Chanel and I talk about Novant Health, we understand and know what the tenets are in terms of living every day, living out every day, our mission, our vision, our cause, our purpose for being. And so it's like when you go to another facility to be cared for, when you're a fish out of water. Okay. Mm-hmm. My experience was I was on I-85 and stopped off at a restaurant, fast food, but top of the line fast food. I don't know any fast food is top of the line, but they consider themselves that. And ordered a Greek salad and broccoli and cheese soup. By the time I got to Durham, I was deathly ill. Ill to the point of just ill. Everything was coming out of me. And I felt as though my heart, there was like some pains I was having around in my chest area. I immediately asked my sister to take me to the ED. And while I presented into that ED, and I will not share the name to protect the guilty, while I presented into that ED, I was asked 5 times, what drugs did I take? 5 times. I'm sharing with the physician that, and also the front staff that are there, what I'd eaten. I do believe that I have food poisoning. I am a registered nurse. I have not taken anything other than the food that I had eaten. I eventually had to get up off of that stretcher and walk out of that emergency room, because by the 5th time that I was asked, are you sure you haven't taken any drugs? As sick as I was, I got up and I walked out. Now, that in itself, stereotyping, it was 9:30 at night. I'm a Black female. I present to the emergency room, and I know that was the thought process as to I am drug seeking. But I was really seeking something to help me throw up so I could feel better. Yes. So again, that particular experience in itself, I know when I'm a fish out of water. I know that what Novant Health ascribes for all of our patients, ascribe for us to be as well in terms of providing care with our patients. And so when we're thinking about that bias and how it shows up, we talk about that systemic racism that occurs, that is a part of that, because individuals, when we even go back to medical school, there is a box that individuals actually live in to educate themselves about the aspect of race. And so it's uncomfortable to really talk about it, but at the same time, it's necessary to be able to talk about it in order to provide for that culturally appropriate care. Yes. And so that's my experience.
Thank you so much for sharing that. I would say that oftentimes it's those lived experiences that truly shape why oftentimes more communities of color have higher rates of these chronic medical conditions, one being cardiovascular disease. Mm-hmm. We know it's the leading cause of death, and it's those psychosocial stressors that communities of color have to go through each and every day. That's one major reason why they have higher rates of hypertension, higher rates of diabetes, obesity, hyperlipidemia. And it comes as no surprise that they also have higher rates of cardiovascular disease. And to that point, I actually want to direct this question to Dr. Calhoun. When we see actually these statistics and these age-adjusted total cardiovascular mortality rates, and we as cardiologists love to look at this data, can you walk us through what that disaggregated data looks like from a race and ethnic perspective as it pertains to the United States of America?
So looking at the age-adjusted cardiovascular mortality between 2007 and 2017, and looking at the age-adjusted rate deaths per 100,000, what is striking in this graph is that the non-Hispanic Black, even though there was improvement over the past 10 years, has strikingly greater mortality, cardiovascular mortality than whites, Indian, Alaskan natives, Hispanics, and Asians. And so this begs the healthcare system to make drastic changes to dispel these racial disparities.
I absolutely agree. And, Ms. Newton, when you go through this data and you see this glaring evidence of disparities, what goes through your mind? What do you think?
For me, it's like disheartening, but I'll tell you what I love is that I get the opportunity personally, every day to share and to make an impact. We all have something that we can do. So I take every moment that I can, because it is disheartening. Someone who was like, I was born with a hole in my heart. A lot of people don't know that. And I have, stitches, I'm 50. So, they didn't do it like how they do it now. But the doctor, he never told my mom. So I have a twin sister. My mom, and I don't know if I've ever even told Yvonne this story, but it's a powerful story. And I take it personal for every person that walks in this door, because the doctor never told my mom. And my mom read the chart, and it says, this twin daughter was born with a hole in their heart. So my mom, not knowing as an African-American woman, that many years ago, she's scared. And they're like, oh, it's going to close up. And so I had heart surgery at almost 3 years old. And so, when I do wear shirts open, and I'm not hiding it today, I just happen to have this on, but people will ask, like, where's that scar from? I didn't know you had, heart surgery. Oh my gosh, you got a second chance to live. Like, I don't look at it like that, but I look at it as every person that walks in the door, because there are people who are walking around with holes in their heart. And so for me, my mom always says she looked at that white doctor who did not tell her, and she heard him talking, and she read it. And I think about the boldness that she had to have to get up and like even read it, that paper chart. Thank God for that paper chart, because she wouldn't have been able to read it if we had electronic. But the fear that she would have lived with. And so having the conversation, my mom knows that I'm so passionate about, community engagement, and why I do, things that bridge the gap with health equity, because I know as African American, sometimes we're not going to be told, or any Black and brown person. Like, I think it's so serious. And so even though I've never had any health issues, because I'm very intentional, about taking care of my health, I run, I walk, I have a trainer, like I eat well, like all those things, taking care of myself, I share that with my staff, because I tell them it is so important to take care of yourself, because these patients coming in here, they're scared. They've gone to the ED. It may have been anxiety, but they don't know that. All they know is they said, come to the hospital. You may have had a heart attack. You may have not, but do a follow-up. So when they're coming in our clinic, a lot of patients are very scared. We got from 23-year-olds, Black, brown, African-American, it falls under Asian, Indian, all these young people coming in, and you hear the heartbreak. And I shared this with you guys when we did a meeting, or one of our first meetings. I heard a young African-American girl, and she was so scared. And I heard her just crying and crying. And I'm like, what is going on? So I go out there. Every day I get the opportunity to lead a team that they know I'm very passionate about D&I. So when these patients walk in, we treat them like this is our home. I take it very seriously. And that we want them to feel comfortable, because if they do not feel comfortable from coming into the front desk, they will not come back to take care of themselves. They'll keep doing everything else, glossing over. You can make it look cute, you can make it look pretty, but I tell them, listen, do you see this? It's pink today, but I normally wear red lipstick. But I really take my health very seriously. And so it's not about the outside, it's about the inside. And do everything you can. You have health insurance, you use it. Go to the doctor. I tell all my staff, from a flu shot to breast, if you're getting a breast exam, let's all go. We get them and we all go together. We do our annual physicals. They're like, oh gosh, Miss Chanel, here we go. But it's changed their life. And so I use whatever space I'm in to tell them, take care of yourself, because you're going to be your best person. We're not all doctors. We're not going to all be doctors, but as having patients, sometimes patients will lie to providers and don't tell you like really what's going on, because they're kind of embarrassed. But, building that confidence that I learned from my mom, go to the doctor. She hears us coughing over the phone. What's wrong with you? Like, just taking that personal responsibility that that might be your husband or your son or your daughter walking in. I don't know that, but I'm going to love them, take care of them, and I'm going to encourage them. Why do you keep no showing your visits? Is there something I can do? Can we get you here? We are intentional about having interpreter services, even though we have people who may speak a certain language. If I hear one of my team members speaking in Spanish and they're not certified, I right then hold them accountable. You are not certified. I want the patient to get the information from somebody who's certified, so that if you're telling the patient something, Dr. Bond, they get exactly what you're saying, not what we assume through a different interpretation.
But first of all, Ms. Newton, thank you so much for sharing your personal story. I just want to acknowledge that you bring up a very valid point that these disparities oftentimes occur even as early as birth. So we see this. So what you were describing was a congenital heart defect. And oftentimes you focus a lot on acquired heart disease, meaning disease that develops through one's lifetime, either due to family history or risk factors. But it's important to acknowledge that we see these same disparities in children as well. And the earlier they encounter it, the more likely they're going to have issues or challenges with their health in the future. And I think this brings us to a really great segue to go to a very important next slide, which is what the impact of these disparities, what they have on cardiology care. And we touched upon, I would say, at least all of them in our discussion so far. So we talked a little bit about resource availability. We know that lower income communities have less access to healthy food. Also, neighborhoods, they have fewer areas where they could walk and exercise on sidewalks or feel safe to go to a park and do exercise. We also know that there are people who may have less access to education. So as a result of that, they may have lower health literacy. Sites of care and access that also encompasses medical services. So people who don't have access to healthcare insurance and also have healthcare insurance, but they're not being provided equitable care, they're going to likely have higher cardiovascular disease. They're going to have higher hospitalizations for cardiovascular disease. And all of that trickles down to the comorbidities and the severity of the burden of disease. So they're going to have higher rates of high blood pressure. Their blood pressure may not be as well controlled as others who have access and don't have these limitations that oftentimes these communities may see. So with all those influences that I just listed, what do we think we specifically should look at? Which ones out of those three do we think are really impacting our patients and the care, more importantly, that we are or not providing our patients mostly? And I'm probably going to direct this to Dr. Calhoun. As a cardiologist, of course, you take care of these patients, but which one out of those three do you think is impacting them most?
I think it's access to care. We really do need to get patients to not only feel like they're welcomed into the medical field and welcomed into healthcare, but we also have to get them follow-up so we can address all these multiple risk factors that contribute to their cardiovascular disease, hypertension, diabetes, high cholesterol. We have to get them to believe in the treatments that we offer them. And it's really important that they feel like they're part of the process, that they're not just a number, that they're being treated individually and respected, because they're all afraid, just like Chanel was saying, they're all afraid of medical care, and they don't really trust the system. But if everyone is showing them that we feel that you belong, we need to help you, I think that they can easily understand and be part of this healthcare process.
Absolutely. And, you bring up a lot of the word trust. And I think a big part of that trust does come with us in the healthcare facility working as a team. And I'd like to actually move on to this next segment, which is talking about team-based care. I know that we've already touched upon it with both Ms. Newton and Ms. Dixon, and I absolutely want you to expand on all the work that your organization is doing as it pertains to that. But before we delve into that, Ms. Newton, are you able to go through some of these concepts, language concordance and cultural humility and staff diversity and training on bias and cultural sensitivity and the impact that may have in improving health outcomes for our patients?
Yes, I definitely, I know Yvonne had talked about, us being culturally aware. And because I have had, the great, benefit to learn a lot more as a professional adult and like going through our program as a facilitator. So I use that. I tell Yvonne, like I was in this African American, we called it Afro American in high school. And I was the chair of our well, we call it BRGs now. And so it was like Afro Cultural Club. And so I always felt like just growing up, I had the opportunity to just love everybody. So for me, it was like, why does there, and I wasn't ignorant to the fact that maybe everybody does not know this, but have an opportunity to help people, you know, as adults. And so primarily in our clinic, I have the opportunity because that is who I lead. Previously working for OSU Medical Center, I did the same thing, but it was information staff. So it's the same thing. You got people, you know, coming into this huge place. And so for me, taking those opportunities, I think I shared with you the example that I used from a scarf we had that Yvonne had sent me for a Christmas gift. And so I try to use specific things because I'm a face-to-face learner. I think people learn it. Sometimes they're like, oh, you guys are talking about D&I. What does that mean? Or what do these pronouns mean? So they know, like, don't say anything inappropriate around Miss Chanel's, what they call me. Because, you know, I'm going to hold you accountable, but in a way that I want you to really get it, because patients know, and you don't know what people are dealing with. You don't know what they're dealing with in their family. So I feel like me being culturally aware and teaching that in every opportunity, even with providers, like when I walk our providers around. So I get that opportunity to tell them, you know, what does diversity and inclusion mean? Why do we have business resource groups? What does it mean with how they impact their patients? Seeing somebody and they ask me these questions like, oh, I love that Novant has, you know, that they talk about diversity and inclusion. I haven't seen it a lot. So I just use every opportunity. You know, I've taught that even in the church atmosphere. And you'd be surprised. A lot of believers like, I don't want to talk about that. That's when you really get to see, do people really care, you know, to say this is really my faith, because you'll see that difference. I learned a lot of things going through the diversity training. So I just use what I learned. I'm very intentional about it myself. And I use what I learned in every opportunity that I have to share that. And so with my team, they've learned a lot. And so the short example, and I shared with you guys, I let them all choose a pair of socks. And then I had them tie it to a situation in their life. Why did they choose that? It grew our team greatly, and it allowed them to identify some biases that they had no idea, but it also allowed them to be culturally aware of their team member and why, you know, something impacted them. And I shared that one, you know, young lady, a really good friend of mine, who she's Caucasian, she's married to a Black man. She chose, you know, the black, gray, and white sock, and she explained how to her why she chose that. It reminded her of her family. So I just feel like any opportunity that I have, I'll talk about it, but I also, I like to live it out in my personal life, in, you know, community engagement, making sure that patients know that, you know, I personally take it, as a commitment that I care for them, even as being an administrator. You know, we need people like me too. And I say that humbly because I'm working for you when your patient, the patient sees me before they see you. So I represent what they're going to see. And if they get an impression from me that I'm not going to welcome them there, it could change what they hear from you to take care of themselves, because they're going to say, I didn't feel comfortable there. So those surveys, I read them to our team. I'm very passionate about our patient experience scores. That's a big deal here. So I read that. This is what we got from a clinical to clerical, even from our doctors. We would call the patients back. How was your experience? How did you feel this way? So even coaching from clerical, clinical, and our providers to let them know this is what the patient says, this is how they feel. How can we do differently, or how can we improve to make sure that we're improving patient experience every time they come in the door? Because we want them to come back and we want their health to improve.
And, you know, you mentioned a valid thing about the patient satisfaction or experience scores, because we know that practicing DEI concepts have actually shown to improve our engagement when it comes to patients. And not just that, our goal, of course, is to improve outcomes. It does that as well. I wanted to actually give Ms. Dixon the opportunity to expand on a study that was, I think, centered largely on everything you mentioned that Novant Health is doing regarding DEI initiatives. And I know that she was an author on the study, and we're really delighted to hear about the study, the work, and where the next steps of this study are and what your organization is planning to do with it.
Yes, thank you, Dr. Bond. You know, providing the diversity, equity, and inclusion education within Novant Health, you know, that began many years ago. And there were some individuals and even some leaders that actually pushed back. You know, we don't have the time, clinical people can't get off the floor, can't leave the practice to be able to come. And that was all during the time in which we were in person. So it was a specific location. Everybody gathered at that location. And of course, you know what happened with COVID. COVID actually put us on pause. And we recognized the very need to continue with the education from a virtual platform. But prior to 2020, we were doing it in person, and doing the education in person, we were able to see people, put our hands on people, you know, stay after the training session to be able to hear from people as to, you know, what they didn't want to talk about while everybody was there. They wanted to talk about it one-on-one. You know, it's kind of like the water cooler kind of discussion, but nevertheless, it was very important discussions. And so through all of the education, actually starting before 2000, and really by 2017, we were looking at the fact that, you know, we've done a lot of education over a period of time. Let's just let's see how well things are improving, not only within the medical practices, but also in our facilities, our hospital facilities. And in doing so, we chose looking at the leaders. How many leaders within our organization? That means the nurse managers, overall, just the leaders of that particular facility. How many of them have actually participated in the D&I training? And we found that those leaders that actually had participated in the training also had team members that participated in the training, but most especially, what we identified is the fact that these particular areas where leaders as well as the team members, but not so much as team members, but mostly leaders, we found that those areas were most improved. Patient satisfaction scores were really great, but not only patient satisfaction scores, it was also the team member satisfaction scores. That really makes a great deal as well. I mean, it is really important. It's kind of like when mama's not happy, nobody's happy. Well, when that team member's not happy, nobody's happy, you know? And so when team members are happy, when they are following individuals such as Chanel Newton, who is modeling those behaviors that they need to demonstrate, it becomes easier, not totally easy, but it becomes easier because you have leaders and physicians who are leaders as well, who are actually demonstrating those behaviors that individuals model. They ascribe to those behaviors. You find team members are much more happier. The retention is much better. The turnover is less. The patients are satisfied. They bring on their families, you know, and then of course, over a period of time, you know, you have even that many more patients that are coming to this practice because the word on the street is, hey, they know how to take care of you there. Right? And so this is what really occurred in our study, is that we recognize, number one, that it's very important not only for our patients to be satisfied, but it's really important for our leaders not only to talk the talk, but talk and walk those behaviors that are necessary in order to be able to retain those employees, or as we call team members,
Yes.
within the organization. And when those team members are seeing those leaders with the behaviors, the language concordance that truly provides for trust and belonging and inclusion, then what you will find is a very satisfied group of individuals. And that's what we had. That's what the study was all about. You know, some people say, oh, that was really big. And I thought, wow, I didn't think it was really big. But then as we are looking at it even deeper, it is really big. So what have we done? What were the next steps, you know, after this particular study is, again, continue with the education. And that is the reason why we went to the virtual platform, because we were not going to stop the education just because COVID reared its head. COVID has not left, and neither has the education.
Thank you so much. And, you know, it's amazing that your organization is doing that. I think, again, all of us can learn from this. And our hope is that starting with the front office team, knowing that they're the first set of eyes, ears, the face that everyone sees for the rest of the visit, they really paint the picture of what that visit would look like. And I want to move on to a few clinical scenarios, really to get the insight of all three of you as experts on this particular subject matter. What would you do? So the first scenario is a woman who's crying, largely because there's a misunderstanding from a technician who was frustrated with her accent. The next scenario was a patient who had missed an appointment, and this was the third time they missed the appointment. We see that quite often. What would we do? Then we have a non-binary patient who expresses concerns that the identity of them is not being respected. And then the last scenario is a patient's very upset because they don't understand their health complications. And I'm going to start with Dr. Calhoun, because oftentimes as physicians, we hear this after the staff has tried to remedy the situation. But as a physician and one of the physicians on the call, could you maybe tell me your perspective on maybe not all the scenarios, but at least which one resonated most with you?
I actually had a very good scenario for the patient that missed their appointment for the third time in a row. I had a young woman, Black woman, that was working in fast food, and she had a cardiomyopathy, terrible heart failure, struggling, she even had an ICD, and she had missed multiple appointments. And so we ended up calling her and finding out, why did she miss her appointments? And she didn't realize that you can have an FMLA form filled out, and that your supervisor does not have the right to keep you from attending appointments when you have a heart illness. And I remember we ended up, you know, filling out the FMLA form for her, and then making sure that she understood that her health depended on her keeping her appointments, and that we really cared. That was really something that just struck me, because it wasn't somebody being non-compliant. She was just terribly afraid and a victim of her situation.
Absolutely. And Ms. Naden or Dixon, do you have any thoughts on these scenarios?
Well, you know, I oftentimes say, seek to understand, you know, because our biases show up, we see something, and right away we go to what is really and truly well, what I know, not versus what actually is taking place here. So when I think about a non-binary patient expresses concerns that their identity is not being respected, and I want to seek to understand what those concerns are for first and foremost, because if this person believes that they are being disrespected, really, then I need to understand what is taking place, what was said, what was done, to make you feel that way. And then once I seek to understand and sharing with this person, and ask the question, how would you like to be referred to? You know, just asking that question, because, you know, we say until we walk in someone else's shoes, we really don't understand what it is that they're feeling. And so in this case, we really have to use that cultural humility to understand, and that seeking to understand. I use that a lot because I want to know, so then that I can push the pause button because pushing that pause button is very important, because I can say a whole lot, but it could be all wrong. So I want to seek to understand by pushing that pause button. And by pushing that pause button, I can think about what it is that I want to say rather than just letting it roll off my tongue and it be all wrong. So having that conversation with that individual. And I would say that the woman that is crying due to misunderstanding from a technician, again, that person is frustrated because of the heavy accent. Ask questions, seek to understand. Ask that person, do you need an interpreter? I can get you an interpreter. Whatever that person needs at that very moment. If we just assume, then you know what that makes us. So when we ask the question of that person, what is it that you need? How may I help? I'm seeking to understand what your needs are. That in itself provides a lot of clarity as to what the next steps will be.
So as it pertains to what we talked about with the clinical scenario, it's important that we acknowledge that there are actionable strategies out there that help us to promote a respectable area of care, either it be in the office, in the hospital, really anywhere where we encounter a patient. And I'd love to direct this question to Miss Dixon. Miss Dixon, can you discuss with us the 5 R's and what the 5 R's are?
Certainly. Thank you, Dr. Bond. The 5 R's are actually surrounded with the things that we think. Naturally, we go into feeling and then, of course, doing. But when we're thinking about the 5 R's, reflection begins that journey. When we are reflecting, we're thinking about how was that encounter with that person? What did I learn from that encounter with that person? Because there's something to learn from every patient that walks through that door. More or less is like, what are they thinking? What are they feeling as well? And what are they doing about, their overall health? So when we think about that reflection, again, it is about each person that we come in contact with. What did we learn from that encounter? Ms. Newton expressed about respect. I often say that respect is earned. At the same time, just thinking about the fact that how did I respect, or how did the front office staff respect that patient? Did I treat everyone that came through the door respectfully? What does that look like? We have to really get our front office staff on board with what respect looks like, not only in what we say, but it's nonverbal communication as well, as to that respect. And then also thinking about regard. Did unconscious bias drive any of my interactions? Because again, going back to bias, we all have it. And when somebody walks through the door, right away, the bias kicks in. And did I really act upon what I was thinking? So we must really and truly think about that. And then that's the regard of our interactions. Then the relevance. How was cultural humility relevant in this interaction? I will say, for me, cultural humility is very relevant in every interaction, because when I am thinking about not so much as myself, but introspectively, I have to come out of myself and think more about that person that I'm interacting with, what they're going through, how can I help them, and more or less leave my biases at the desk. And so that, in terms of that relevance and that cultural humility, again, that interaction that I had with that individual, was I thinking about myself, or was I thinking more about that person that I am interacting with? And then finally, thinking about the resiliency. I wrote something the other day. I said, I'm just tired of being resilient. Just respect me and I'll be just fine. But truly, when we think about resiliency, how was my personal resiliency affected by this interaction? Can I come back from that? It was an interaction, and it was an interaction with that patient that was just really crying and really, disturbed over the fact of how they're feeling about their health, how can I come out of that? How can I help that patient, come out of that feeling that they're having, to help them to not feel like that they're doomed, but to do more about their health, and how I am able to impact them through the reflection, which is the interaction, the respect that I provide them, the regard for the fact that, I have put my biases aside, the relevance of that interaction, and then finally the resiliency. How can we come back from all of this? So I hope, Dr. Bond, I was able to provide you with the respectful 5 R's as you would like.
Thank you so much, Ms. Dixon. No, you did an amazing job. And, those 5 R's are there to shape the conversation and how we interact with patients. And there actually are methods out there that help us furthermore to engage with patients. And there are acronyms for these methods. One is respect. So like Aretha Franklin always says, we need to have that respect. And, with the respect model, the first portion of it is respect, as it should be. Then kind of expanding on that is the explanatory model, the sociocultural context, power, empathy, concerns, and fear. And then lastly, the therapeutic alliance and trust. And I'll open this up to all on the panel. Are there ways that we can perhaps best express this and live by this with each of our interactions with patients? Perhaps Dr. Calhoun, you want to take that?
Yes, I think we have to show all patients respect, regardless of their race, regardless of their background. We have to show them that, we want them to be part of our practice, that we really want to help them. I think what is so important is that we try our best to provide interpreters when patients are having issues with communication, to help them, ask them to bring their healthcare advocates so we can communicate better, to provide the best explanation so when the patient leaves there, they understand what their tasks are and they understand what is expected of them as well. But making sure that we empathize with the patient on every level, to make sure that they understand that we really are tailoring our care to them.
Thank you so much. And honestly, we had such an amazing discussion today. It truly has been a pleasure to speak to each and every one of you, very strong and powerful women. I want to leave this panel discussion with giving you the opportunity to talk a little bit about specifically the way that it would be best to interact with patients in a way that could help promote a respectful care model, and any pearls that you have for the audience that we could leave them with today. So let's continue with Dr. Calhoun, being you were very eloquent in your last conversation. So what are pearls you would leave the audience with today as it pertains to patient care?
I think, as Chanel said, understanding that patients are afraid, patients are distrusting, patients want to know that, they're not going to be harmed by healthcare, by medications, giving them that great smile when they come in, to let them know that they are welcome, that we want to help them, that we want to bring them back and give them good care, that we want to make sure that they feel comfortable about everything that we're doing for them and that they feel special. I think that, the front desk is the first smile that a patient sees, and it sets a tone for the entire appointment, making the physician aware if any concerns of the patient, so that the patient, the physician or the provider can focus on those concerns that the patient has.
And Ms. Newton.
So I would again say, as a clinical or clerical leader, for me, I think it starts with that leader, because you have these team members looking at you and how you treat them, because I treat my team very well. They treat our patients well. And so that smile, they see that, but it's very genuine behind the door. When they see that I care for them, they're going to work hard, because sometimes they have opportunities where patients come in and they're like, we walked into clinics for years and it might have been all Caucasian, but sometimes we've gotten feedback where patients like, like, why are you guys, wearing African American shirts, during Martin Luther King holiday? So for me, that first step, really, one person is impacting, I have 20 team members. So how I treat myself, how I carry myself, and how I treat my team, it's a huge influence and impact on how our team treats our patients walking into this clinic. It makes them walk back. They pull me and say, I love your team. I love how everybody smiles and gets along. And we step up and we help when we see somebody struggling, like they feel uncomfortable coming in. I'm like, welcome in. I treat them like they're coming into my home, because I may be the only representation that they have of Novant Health. So it doesn't matter what's going on behind the scenes. I give them this experience, like, you are welcome here. I want to, use whatever opportunity that I have to make them feel welcome, and to let them know Dr. Bond is going to be great, because they walk in, but I don't know who Dr. Bond is. Is she going to take good care of me? I'm scared. So I just use whatever without giving clinical background, because I can't, but there's a whole lot that I can give them an impact on their experience before they get back to you, whether it's their insurance, them feeling, comfortable. I always offer water. They kind of people with me like, Miss Chanel, you're giving out seltzer water, whatever it takes. I just treat them very well, and it speaks to our patient experience scores. It speaks to, the awards that we've won, not just because I want the award, but I really take every day when I walk in, I'm happy, our team members are happy. Is there something going on? What can we do to make our work experience better so that our patients can see it?
Thank you so much for sharing that. And Miss Dixon, please take us home.
All right. When you love yourself and you show love not only to yourself, but others can see that, hey, she loves herself in a respectful way.
Yes.
And when people see that you love yourself, they know that not only do you love yourself, but you're showing love to others who are different. All of your 20 team members that are within the practice, Chanel, they're all different. And showing each of them love, I would often say, showing them love in a way in which they are able to receive it. And so you do that. And we're most better for it, in showing that love in whatever way that you can. And when patients see that coming out of you to your people that work there, team members that are there in the clinic, then patients will see, I'm going to be well taken care of here. That's what we want. That's the bottom line. They want to be taken care of when they come through the door and they don't know us. But at the end of the day, at the end of that visit, they should know us and they should trust us. And that comes by way of us showing love to ourselves first. It will permeate out into others, and our patients will feel that, and they will not only respect that, but they will come back because they'll trust us.
Absolutely. I love that. Love ourselves first. I concur. Now, I just want to thank you all again for such a wonderful and enriched discussion. I want to wrap it up by actually going over a few SMART goals, which are really what we hope the audience will take home with as you understand more and more about the practice and how best to kind of navigate sometimes a very complex healthcare system. So our SMART goal standards for specific, measurable, attainable, relevant, and timely care. Number 1 is apply key concepts related to diversity, equity, and inclusion to patient interactions at the front office points of contact. Number 2, identify and reflect on personal implicit biases. Number 3, engage all individuals seeking cardiology care with empathy, cultural humility, and respect. And with that, I thank you all for joining us.